Hello, Peter. How are you? Welcome to the
Hi, how are you?
Masterthon. I'm good.
Thank you so much, Barbara.
I have to introduce you properly now because that is really important, and it's really important that you're here with us today. You're Professor Dr. Peter Hotez, Dean of National School of Tropical Medicine. I need to read that, and co-director of the Texas Children's Hospital Department of Vaccine. And you've been working on vaccine, especially on the COVID vaccine as well, for the last 10 years. Is this correct?
That's right. We've had a big coronavirus vaccine program. We make vaccines for poverty-related neglected diseases. The vaccines generally big pharma companies are not interested in making because they're for the world's poorest people. And then for slightly different reasons, we developed a coronavirus vaccine program a decade ago because nobody cared about them. We recognized that coronavirus vaccines were going to be really needed because we saw that virus infection called SARS, severe acute respiratory syndrome, that started in 2003 out of China and affected Toronto, Canada. Then there was MERS coronavirus infection in the Middle East. So we knew coronavirus infections were here for a while. And we've always struggled getting people to care about coronavirus vaccines, just like our other orphan vaccines that we work on. And then I guess something happened around December and January. Suddenly people got very interested in our coronavirus vaccines. But we have a very unique approach and relevant to what you're trying to do today, which is that we're trying to develop maybe the first global health coronavirus vaccine. That is a low cost, accessible vaccine that uses a technology that could be reproduced all over the world. So we use the same technology to make our COVID-19 vaccines that are used to make the hepatitis B vaccine made in places like India and Brazil, because our concern is some of the vaccines that are being developed can't be reproduced easily in terms of scale at manufacture in many low and middle income countries. So we're trying to make one specifically designed for that purpose.
So one of the leading professors and figures in the world of vaccines, and you said to me it's probably not so difficult to make this vaccine. I want to ask you the most important question everybody is asking right now. What is the timing? When can we think we have a vaccine and or possible treatments even?
Well, I think the treatments may come faster than the vaccine. Vaccines have a pretty high bar in terms of getting them out there, because with a vaccine, remember, you're generally immunizing well individuals to prevent them from getting sick. So your bar in terms of safety and showing that it works is pretty high, and that's what takes the time. So we've got our vaccines ready to go into clinical trials. There's going to be at least a dozen, maybe 2 dozen vaccines that go into clinical trials, each using different technologies. But then the bottleneck comes because you have to give it adequate time to accumulate enough data, evidence that the vaccine both works and is also safe before we release it to the public. And that's unfortunately the slow part. And that's why it's really hard to accelerate new vaccines in the middle of an epidemic or a pandemic.
So what is the timing? I need to have now.
You're going to really hold me to it. Yeah, we're hoping next year that our vaccine's going to be ready, and probably the other ones as well. You're hearing some crazy things, like we're going to have a vaccine ready by the fall.
I know. Or there's so much out there. Like every company is working on vaccines now.
Yeah, a lot of that is hype, from the pharma companies and biotechs talking to their investors. What they really mean is they can have it manufactured by then, but to know that it's both safe and effective, I don't see how you accumulate enough safety and evidence by the fall. I think it's probably going to take till next year, which would still be a record, right? I think one of my colleagues pointed out the record for going from start to finish to have a vaccine out there is 4 years. So we'd still be breaking it. Even if we have it next year, we'd be breaking it by 2. So we're doing our best. I've just had to give up sleeping, and my colleagues have had to give up sleeping. And we wake up early, and we're on we have either our team is in the lab or on the vaccine, or on constant teleconferences. and we're still raising money for it. It's amazing that we still struggle to raising funds
Oh,
for
wow.
this.
So
Yeah,
this is
so
another
that's
area we should look into in getting funds for you in order to get the vaccine. This is so important right now. So thank you for doing all this like night and day work with your team. This is really great. What about, I come from the history a little bit of blood plasma treatments, and they're right now collecting lots of antibodies from people who already had corona. What do you think about that?
Yeah, I'm pretty excited about it, and I've been out there kind of championing it. It's kind of an old school approach. We did this during the 1918 flu pandemic, and it actually worked to some extent. And now we have better techniques in terms of measuring antibodies in the blood. So you only use plasma from patients that have high antibody titers, so you can stack the deck in your favor that way. And we're starting to see some early evidence that it's working. It worked for the first SARS pandemic in 2003, and I think it's going to work now. The problem is it's somewhat resource limited because you have to have donors, patients that have gotten infected, developed antibodies, and then recovered. So the scale up is a bit of a problem, but it does seem to work, and it points to the likelihood that future vaccines would work, like our vaccines, and it points to the fact that you can use it to design monoclonal antibody therapies, which can be scaled. So I think you'll see some of those move out as well. So it's an important finding, and it's so far it looks like it's life-saving. The thing about convalescent antibodies, you have to give them early on in the course of the infection before patients get really sick, because what happens later on in the course of the infection, they develop all that cytokine storm and inflammatory response, and then the convalescent antibody won't work as well, or at least that's what we postulate. Okay,
then I have another question, because I'm all about inflammation and fighting inflammation in our system. How is the inflammatory effect on our bodies?
Well, it looks like there's two phases to this illness. The first is caused by direct virus infection. And that's causing damage to the lungs. It's causing damage to the blood vessels, because the receptors for this virus are found in the blood vessels, even damage to the heart. But then later on in the course of the infection, things are exacerbated because of that host inflammatory response. And so some of the most severe lung disease is due to host inflammation. We also are seeing terrible clotting problems in patients with COVID-19. So we're seeing pulmonary emboli forming. We're seeing strokes, maybe some of the coronary artery disease, and exactly how much of that is due to the virus versus the host inflammatory response, we still don't know. So there's, this is a brand new virus. This is one that this time last year, we didn't even know it existed. So we're learning more and more about this virus every day, and I'm amazed at the pace of the scientific community, and as well as the international cooperation, scientists putting up their data as soon as they get it on preprint servers, and we're doing the same and they're doing it. So it's really fabulous to see this level of scientific cooperation. It's also really nice to see scientists communicating to the public now. That's something that really hasn't happened a lot in the past. So you're turning on the TV, you're seeing scientists and hearing from scientists, and I think that's so important, because we're, as a group, we tend to be invisible and nobody really knows what we do, and that's good to have that face. And so that's why
everybody wants education right now. So really thank you for doing this. One more question, and then I will let you go. But what is the predisposition from patients? Some patients don't have any symptoms, others have terrible symptoms or die. Why is that?
Well, in some cases we know that older individuals seem to be more susceptible to severe disease. Those with underlying diabetes or hypertension or kidney disease or even obesity are more at risk. And so, a lot of people living in poverty, unfortunately, often have higher rates of diabetes and hypertension. So we're seeing this also as a health disparity. And then there is still that individual young, healthy adults who gets really sick, and that's not as common, but we still see that occasionally. So still trying to understand the basis of susceptibility and why some people get so sick. And we know that up to maybe half the individuals have no symptoms at all, which is extraordinary. And that's what makes it so hard to control, because in any given community, people walking around with asymptomatic COVID-19 infection. And so this is the problem. One group getting so sick and in the intensive care unit, the others seemingly fine. And we're all really struggling figuring out how to control this without a vaccine, or hopefully we can get that vaccine out soon.
And that's why it's still really important that we stay home, that we really are cautious with our hygiene and social distancing. We have to keep doing this for a while. And so this is really interesting insights. Thank you so much, Peter. So amazing you could join, giving us your time. And thank you for dedicating all of your time to finding the vaccine, which is so needed. Thank you.
Well, and thank you for giving attention to the science. I deeply appreciate it, Barbara. And thank you for all your great work.